And in melanoma, I've discussed that with you already. We're looking at it at the moment, and I'm not sure, we haven't made any decision right now on melanoma using BRAF and a drug that targets, I think it's the wild-type BRAF. In breast cancer oncotype D, we have uncertainty of oncotype DS because of low quality evidence. So we're now running a field evaluation study, Mark Levin's group is, and we gave him, I think this is an expensive study, we gave him about $750,000, and the Ministry of Health paying for the test, which are done in California, in addition to that. And we're looking at the impact that oncotype DX will have on decision making for patients and for breast oncologists. And we just completed dilated cardiomyopathy as a predictive test, and there's just no evidence there. And we sort of can, who in the right mind is going to use that, and I don't think we're going to pay for that. So finally, personalized predictive genetic testing is clinical research and policy implications. We need a decision framework for this stuff, and I'm really worried about it. Predictive genetic testing, we are meandering around, it's on us, and the human genome, you can go and have it tested probably this week, next month, cost you less than $1,000, and it'll tell you you've got a 20% risk of having a myocardial infarction in your lifetime, and a 30% risk of having rheumatoid arthritis. I don't know, it'll give you that profile. We have not developed a decision framework in terms of what we're funding and how we're funding and what our strategy is for promulgating this to the public. Because there are all kinds of issues. I've got more questions than answers on this. What is our predictive risk threshold when approving a test? Now for BRCA1, BRCA2 and breast cancer, it's a no-brainer. You've got an 80% risk of developing breast cancer in your lifetime. If you don't provide that test, I think you're almost negligent as a healthcare provider. I mean, that is, to me, it's not slam dunk. But what happens if the lifetime risk had been 10%? Would our policy have been the same? And when an effective, that's the predictive test threshold when there is an effective treatment and when there isn't an effective treatment. What are the outcomes you're going to use to justify the predictive test? What cost utility threshold are we going to use for the test? And how are we going to account for environmental factors in any modeling? And here's a table of some of the harms, and this is top of mind. I did not go and do any kind of research on this, and I have to be honest with you. But some of the top of mind issues, harms to patients and systems, and some of the benefits for some of this predictive testing. Well, the harm to a patient is creating unwellness. If you go and have your genome tested and you have all this kind of thing about what's going to happen to you in the next 50 years of your life or 40 years of your life, you could create unwellness, especially if there's nothing you can do about it, by detecting it early. The benefit is risk mitigation, if that's applicable, through early detection. That's a real benefit. A harm, right to know when there's a low predictive effect of the test. A benefit, right to know when there's a high predictive effect. Huntington's chorea is a real good example of that. Patients with Huntington's chorea will tell you, because we did this survey with patients, not a survey, but we had them on a genetic panel. They want to know, you've got such a high predictive effect. They want to know whether they're going to get it or not. A harm, unproven interventions and tests. If you have a 40% chance of a myocardial infarction in lifetime, and you make a pest of yourself to a family physician, I bet you dollars to donuts, they will do an echocardiogram on you once a year. They will do an exercise tolerance test on you once a year. They will start doing CT angiography on you at the age of 30. And we haven't got a clue whether any of that makes any difference to mitigate the risk that has been determined through predictive testing. On the other hand, the benefit is appropriate behavior modification if you have that risk. Well, there are two examples of that. One is calcium scoring on CT angiography or its predecessor. And in a study that was done, they found that the risk for coronary artery disease by calcium scoring of the coronary arteries on CT angiography made no difference at all to behavior modification for those people who are at risk. None. they're unable to change their lifestyle accordingly. Whereas for BRCA, we know that people are having oophorectomy, they're going on drugs to mitigate risk. So it's a kind of a mixed picture, but it would be a benefit. The complications from interventions when you have a test, following a positive test, resource implications with counsellors, how you're going to set this thing up. And I think, a negative test can be a harm. Because if you have a negative test for screening heart disease on a predictive genetic test, you're going to start probably eating all kinds of McDonald's, and you're going to stop exercising, and you're going to say, geez, I look at a risk. I'm just good, thank you very much. Well, that reckless behavior could be a downstream effect of a negative test. On the other hand, if you have dilated a hypertrophic cardiomyopathy and you test negative, you'll be relieved that you don't have that genetic susceptibility. So it's a kind of a mixed picture that we have to be cognizant of as we go along. I put the slide up just to be complete. I'm not going to go through it in any great detail, but I want you to understand the complexity of a predictive genetic test. Cost attributed to a test, to counseling, to immediate and lifetime additional diagnostic tests, to physician visits and interventions. And cost effectiveness, how we're going to measure it, what's the utility we're going to use in cost effective analysis. So this is going to be really interesting, and probably most important, what is our lifetime span for these economic analyses? Is it going to be from 20 to 90? Is it going to be from 20 to 70? How are we going to compute that in our model? And these are unanswered questions, unfortunately. So we always need to consider the comparative and not absolute effectiveness. The clinical trials, I don't know how we're going to do these clinical trials. They're going to run for 40, 50 years. I suggest two things. One is we might have to have surrogate outcomes. And secondly, we might have to use economic modeling based on existing knowledge. And I don't know how we're going to even get around this, because you can't run a clinical trial that runs for 40, 50 years. And how do we measure the threshold for making policy decisions in terms of risk? And how is the relative contribution and outcomes on environmental versus genetic factors determined? And no one's thought that through. I'm convinced that no one's thought that through. I'd say it as a statement in provocative about it. So EGAP, I'm almost finished. So sorry, Brad hasn't stood up yet. So EGAP. He's standing. Okay. Well, too smart, so EGAP is a big group funded by NIH in the US. And this is their track record on genomic tests published in 2011. And you can see that in this column on your left side, you can see that they have made recommendations that do not support the introduction of some of most predictive genetic tests to date. I can't go through this slide, I'm not allowed to. So my second last slide. We've got to be really careful that we're not guilty of genetic reductionism. So I think Alan or Brad asked me last night, what do you mean by genetic reductionism? I've got a very simple definition. When you have a plate of spaghetti in front of you, if you see DNA helixes, you are a genetic reductionist. Okay, so we've got to be really careful that we look at what you're doing through a much broader lens than genomic and genetic research. You've got to contextualize it with other determinants of risk, normalize within the context of burden of proof and evidence-based analysis, simplify it for policy decision making. Don't go in there talking about the high-tech stuff, great stuff that you're doing. Simplify it, make it easy. Tell them that this is no different from tamoxifen. Tell them that tamoxifen is a great example of a precedent-setting policy and how you want to expand that. And finally, tensions in the health technology debate. I put this up at asked to present something to a group, and this is by courtesy of Charles Dickens, and it comes obviously from Tale of Two Cities. But it's worthwhile thinking about in the context of where you are at the moment. Because the best of times, because the worst of times, It was the age of wisdom, it was the age of foolishness, it was the epoch of belief, it was the epoch of incredulity. It was the season of light, it was the season of darkness, it was the spring of hope, it was the winter of despair. We had everything before us, we had nothing before us. We were all going direct to heaven. We were all going direct the other way. So that's my final slide, and I think that's where you are in healthcare, and I think that's maybe where you are with your with genomics. Thank you.